right, so let's get started without further ado. Thank you guys all for coming. You guys are very dedicated, showing up, getting your weekend started with us here at Motivate MD. This is our fifth, I believe, virtual rounds session. My name is Emma. I'm a third-year medical student at Burrell College of Osteopathic Medicine. Speaking of which, I see some of our New Mexico State students here, so I have to give them a shout out. I know they're always very dedicated. And today we're going to be talking about thyroid disorders. So you guys are probably familiar, even at your level, about thyroid disorders, hypothyroidism, hypothyroidism. We're going to talk a little bit about each of those things. And I'm going to make it pretty simple for you guys, so don't worry. You know, as always, we want you to be very interactive with us. We want you to answer, be involved. Don't be afraid about getting questions wrong. I've probably gotten a billion questions wrong still at this level, so don't be afraid to engage with us. That's the way that you learn, okay? So let's keep going here. So we do have a few updates that we want to share with you. So we kind of, as we're evolving, we changed our formatting a little bit. We're going to continue with the SOAP notes. So those of you, the familiar names that I see from the last few times, we're going to continue with that SOAP note. Becca has put that in the chat for you all to fill out during the presentation. This is really going to be an opportunity for you all to practice your medical documentation. Even at an early level. Trust me, it'll certainly kind of help you. It'll help prepare you for medical school. Okay, and then afterwards, we do have a quiz. In order to get the certificate of completion for this session, you will have to answer 80% or higher on the quiz. These aren't trick questions. They're not immensely hard questions. I think you guys can after having you know, participated, been involved, it should be pretty easy for you guys to answer and get at least 80% on the first try. That being said, if you don't and you need a second attempt, we'll give that to you as well. So you can get a certificate of completion for that. Becca just put the link to the presentation slides so you guys can make notes if you need. Please make a copy to take notes on. That was her note. Other than this, we do have a Google folder for you guys. We have some info and resources for you. We really want to be an asset to your pre-med journey. I believe in that. I came from a family of no one was even involved in medicine at all, let alone doctors. So, you know, I kind of figured it out as I went. So it's near and dear to me that we're an asset to your guys' education. And then if you guys have any questions at all throughout the session, feel free to unmute yourself or throw it in the chat if you'd like. I'll keep an eye on the chat box, and so will Becca. So for me, I'm going to add something in for you guys. The other presenters may not, but I wanted to add in something for you. I like reading when I have the chance. So this is a book that I'm reading currently. It's called Soul of a Doctor. And I like this book because it's a bunch of compiled essays that medical students write. So it's nice whenever you only have a little bit of time to read, you can read a couple essays here and there, and you won't forget the plot of the book. So this one is especially good for me when I kind of read sporadically. I think this is a good book, and so far. And Jerome Groopman has added a foreword to this, and I thought it was very insightful, and I like it a lot so far. So keep note of this. I think it's a good read for you guys at your level as well. Okay, so last time I chatted with you guys, I didn't have a joke for you. We were talking about leukemias. I thought it would be distasteful. I've added 2 jokes in here for you guys. I made up for the last time. So I'm sure that you've, if you're a scribe, if you shadow, you've probably seen a lot of people hope that their weight gain after the holidays is associated with their thyroid, because maybe they can take some levothyroxine and maybe lose some weight as a result. But with that being said, I'm going to give you guys a poll here. We're going to start out with a poll. And this is for me to really gauge your guys' knowledge about thyroid. disorders. So go ahead and answer some, or answer this question for me. I'll give you a few minutes, about a minute here. Or whenever I see 34 people answer. All right, a few more seconds. All right, we'll stop it there for sake of time. Let's share this with you guys. So this is what you guys said. I think the vast majority of you guys know some, which is great. So, and then whoever said they know a lot, I want you to unmute yourself and present instead of me. But I'm glad that some people also know a lot. You guys, if you know something that I missed, feel free to throw it in the chat. I'm sure there's stuff that I can learn from you guys as well, okay? Those of you who don't know anything about thyroid disorders, that's perfectly okay. Hopefully by the end of this, you pick up a little bit of that and you can learn a little bit. All right. So with that being said, let's jump right in. So here's kind of our outline here. Very similar to the last few times. We're going to start out with a case. We're going to go through the physical exam, differential diagnosis, assessment, and plan. And then we're going to talk a little bit about the pathology. And so really what your guys' role is today is going to be to participate. I'm going to ask you lots of questions. I'm going to have a few polls again for you guys to engage in. And I think that I've gotten very positive feedback from you all that this is a helpful way for you guys to learn. I know that when I learn myself, I have to do something active. I'm not a passive learner myself. Other than this, fill out that SOAP note and then be sure to ask questions. Obviously pay attention. It'll help you whenever you're doing your quiz later on, and then you won't have to Google the answers. You'll just have them off the top of your head. And then at the end, we would love it if you gave any feedback about the session. All right. Here's the SOAP note form as kind of a review. The subjective portion is going to be your HPI and your ROS, the HPI being your history of present illness. So you're going to talk about this subjective portion that the patient says. The ROS is going to be pertinent positives and negatives. You know, for instance, maybe thyroid disorder, they gained weight and they feel tired. So that would be positive ROS. And then the other thing that we want to include is the objective portion, which is the vital signs in our physical exam findings. And then assessment and plan. Assessment is going to be basically our differential diagnosis, what we think. And then our plan is what we're going to do in order to address what we think our differential diagnosis is, or our, you know, or the condition that we're looking at right now. All right. All right, and then let's, for those of you that remember, let's mark where you guys are at. I'd always like to know where everybody's at. So you could go to annotate, pick the stamp, or if you want to draw it in, and mark where you're at. So I'm in El Paso. Cool, we have New Mexico. I think those are NMSU students. Some Texas. All right, we have Tennessee. Lots of Texas. I think everybody's overwhelmingly from Texas today. Oh, we have a California. Good. All right, I'll give you guys a few more minutes. Not on this map. Zena, where are you at?
Hello, I'm in Ghana and it's 1 a.m.
You're immensely dedicated. So you're a night owl. Okay, for next time, I'll add a little Ghana flag or an icon for you, so you're not left out next time. So we have a minute.
Thank you.
Absolutely. Thanks for being here. All right. So we have a Minnesota and we have a California. Okay, guys, let's get going. Thanks for marking your locations. Oh, I gotta clear that. I always do that. All right. So here's our case. So A 35-year-old attorney presents to the clinic with worsening fatigue. She notes that for the past 2 months, she has been experiencing lingering tiredness despite sleeping 8+ hours per night. She denies any depression and states, I'm too busy for that. But does report constipation, hair loss, a 10-pound weight gain over 2 months, despite not feeling very hungry. She notes that at the firm, most of her co-workers are bundled up with as many, many of her co-workers are hot, I'm sorry, and she is bundled up with as many clothes as she can find. Her last normal menstrual period was normal, though she does admit that it was a little heavier than usual. She states that she has felt very well with a lot of energy, she has felt very well with a lot of energy, but recently had a cold and felt terrible following this. She has no significant past medical history. So as you've kind of been able to tell, she has a few symptoms that we want to keep our eye on here. Noteworthy ones probably are the ones of which are bolded. So let's go on to our next slide here. So some questions that we want to consider. The first being, what other things should we ask our patients? So what are you guys thinking? Is there anything that kind of came to your mind after we read the case there and we said, you know, what I wish I would have known this information? Is there another question that we should ask this patient? If she takes medications, good. Taylor, I assume that your kind of question is if she has a history of hypothyroidism, which is certainly a question that we want to ask. And along those same lines, perhaps we would want to ask if she has a family history. Good job. I was just about to say that. So Emily took the words right out of my mouth. We would want to ask if there's a family history of hypothyroidism, any thyroid. Does she have a history with PCOS? Good job. Often runs with hypothyroidism. I'm starting to think Maddie's the one that put that she knew a lot about thyroid disorders. Okay. Anybody else? Okay. Walter says any other diagnoses or any changes in meds recently? Good. Good. Anybody else? Any other thoughts? That's great so far. The next question we want to consider is what details are of the utmost importance? What is kind of lingering in your head that's like, this may be something going on? Cold all the time, weight gain, tiredness. Good job, Holly. Perfect. Those are 3 big symptoms that were given in the vignette that we certainly want to take seriously. You're absolutely right. Especially, and it may have seemed like a subtle detail, and I'll mention it while you guys are still brainstorming and putting things in the chat, but her occupation was that she's an attorney. So we know that she's busy all the time, yes, but we know that she works hard. So maybe, you know, that tells us that she is aware of her energy level, perhaps. Sometimes the jobs can kind of give us an indication of what they're doing on a daily basis, okay? Any other ideas? What other details are important to us so far? Changes in menstrual period, perfect, good job. Yeah, heavy flow is absolutely associated with thyroid conditions, hypothyroidism specifically. When the symptoms started, yeah, we can certainly ask her that as well. That's another question that we want to ask her. Anybody else? Hair loss, perfect. Good, good. And then Holly, another question that we can ask on that same line is, what are we talking about in terms of hair loss here? Are we talking about like clumps of her hair falling out, or like when she brushes it, like one strand of hair comes out? We definitely want to delineate what her hair loss is. Same thing if people are telling you that they're gaining or losing weight, we want to ask them in what period of time. If they tell us that they have gained 10 pounds in a year, that's probably less significant to us than if someone did it in a shorter period of time. Limited appetite and gaining weight, perfect. Good job, Mackenzie. History of Raynaud's, yeah, we can certainly ask that, because as we may be getting towards it, is that if she has one autoimmune thing, or we're looking towards an autoimmune condition, then Other autoimmune disorders may be more common. Lingering tiredness, but sleeping 8 hours. Perfect. Nathan, you're absolutely right. I wish I could sleep 8 hours. That would be nice. But at any rate, she's sleeping 8 hours and she's still tired. Okay, good. Good job, guys. Okay, so next question that we want to consider is how should we proceed? What do we want to do at this point? Do we tell her, go home, you're okay? You know, you're probably just working too hard. You're an attorney and you work long hours, so you're probably just tired. Good. Blood test for TSH, blood test for thyroid. Good. Any other tests? Do we get imaging for her at this point? And what other labs do we want to consider? Biopsy, potentially. Anybody else? Do we want to get imaging? You can just tell me yes or no. Anemia, good. Yeah, good, good. Not unless there's something significant like a lump. We could consider doing a CT, sure. But I would say that we want to make sure that we have an indication for it at this point. So I think you guys are right on that, right on track in terms of her symptoms. Let's start with the TSH. Why not? That's such a simple test, a simple blood test. Okay. So good job. And what body areas do we want to examine on this patient? Name anything and everything that you would want to take a look at. Her neck, good. We want to look for goiters, good, perfect. So these are things, by the way, that we want to look out for in the physical exam. Anything else? Are we only going to look at her neck and then walk out of the room? Do we want to listen to her heart? Or not really? We just want to do a focused physical exam. Her eyes, good, good. Whoever said eyes, perfect. Oh, it's Becca. Way to go, Becca. Perfect. We want to listen to her heart. Taylor says abdominal, good, good. Especially if she has weight gain, good job. Anything else we want to take a look at, guys? She has constipation, so we want to look at her abdominal area, absolutely. Blood pressure, good, perfect. Yeah, we absolutely want to look at her blood pressure. We want to look at her vital signs specifically, so good. Anything else? All right, let's look at the physical exam. So as you can see here in the upper right-hand corner, that's her neck. So we did look at her neck. So all of you guys that said to look at her neck, there you go, there's her neck. Is that normal? No. Yeah, Holly, you're right. Everybody that's saying no, you're absolutely right. That's not normal. It's enlarged, it looks diffusely enlarged. What we want to look at when we see someone of whom has a goiter is we want to look and see if it's enlarged in one area, aka if it's a nodule in one area, or if it's diffusely enlarged. As you can kind of see here, let me get out my little pointer here. Let's see. So her thyroid is diffusely enlarged. So, and we see that there's no nodules. Okay, that tells us a little bit. She's tired appearing. So in addition to her telling us, we see that she's tired appearing. Which vital sign is kind of important to us right now? Low heart rate, good. She's bradycardic. She has a heart rate of 54. What might be a question that we want to consider for her? If she has a low resting heart rate, what do we want to ask her? So we see also in the CB exam, is she active? Perfect. Exactly. Because if she's a marathon runner, she's going to have a low resting heart rate because she has a high metabolic activity. Okay. Other than this, does she take rate control medication? Perfect. Good job, Walter. Perfect. If she's on a beta blocker, that's definitely going to lower her heart rate. It's going to affect correspondingly her exercise. She might not be able to raise that heart rate because of the beta blockade in the heart. All right. Her lung exam is normal. Her abdomen is normal. And we have dry appearing skin. Is this significant, or does she just not have time also for a lotion? Somebody let me know real quick before we go on to the next slide. It's significant. Good. Good. Yeah. So what the picture we're starting to kind of see now is maybe it's a thyroid disorder, especially given her goiter. And dry skin can certainly come along. Skin conditions can come along with the metabolic activity. All right, guys. Let me clear all this and let's go on to the next one. So here's her labs. You guys asked for a TSH, and we got one. We have a TSH here. We see, so I put a key for you guys. You're gonna see when you get on the wards that often residents, attendings like to write out their labs in kind of this fishbone appearance. It's in the key is kind of in the upper right-hand corner. So as you can see, her CBC is normal. She's not anemic. Her CMP is normal. She has a normal glucose. She has has a normal sodium as well. And then the labs that we are kind of concerned about or should be concerned about here are her TSH. Her TSH is elevated and her T4 is correspondingly low. And of note, someone was very wise and they ordered a thyroid peroxidase antibody. Sometimes if there is hypo or hyperthyroidism, there may be an autoimmune cause of this that we need to look into. Not that the sort of treatment is necessarily different if it's, you know, autoimmune hypothyroidism versus other types of hypothyroidism, other primary hypothyroidism, but the test is available, we can see. That way it may point us in the direction of other autoimmune causes that you guys had indicated before. Someone said the TSH is high. You're absolutely right, that TSH is very high. The cutoff is around 4 to 5. Okay. Anyone have any questions at this point before we kind of go to the next slide?
Why is the skin dry and significant? Or sorry, why is the skin dry significant?
Yeah, good question. So it's significant because sometimes if we have a hypothyroidism, or even if we have hyperthyroidism, we'll start first by talking about hypothyroidism. If we have hypothyroidism, the metabolism is low. The thyroid is underactive. It's kind of lazy. That's the way I like to look at it. And therefore, the skin is correspondingly dry due to decreased metabolism. On the other hand, hyperthyroidism is kind of the opposite of that. And a lot of times you see basically the opposite symptoms. So I always say, if you know one condition, you know the other one because it's the exact opposite. You have a high kind of metabolism and then you see sweating. So it's all kind of corresponding to that metabolism, okay? And then we had another question, why do you test for TSH and T4? Great question. We're going to talk about that as well. And you're absolutely right, Zena. It's to kind of delineate whether it's a primary cause or a secondary cause. And if this sounds right now like I'm speaking a foreign language, that's okay. I'm going to explain this in a minute. It's kind of to delineate where the problem is exactly, whether it's with the hypothalamus, whether it's with the pituitary gland, or if it's with the thyroid itself. Low T4 indicates hypothyroidism. We're looking a little bit more in terms of hypothyroidism at the TSH. That's the gold standard for diagnosing thyroid conditions. Could anti-TPO indicate Hashimoto's? Perfect. Great job. That absolutely indicates Hashimoto's thyroiditis. The other autoimmune or the other antibody that we look at is antithyroglobulin as well. Those two are for Hashimoto's thyroiditis, which is an autoimmune etiology of hypothyroidism. Okay, I'm trying to make sure I didn't miss anybody here. Is T4 always tested? I've typically heard of TSH levels only being tested initially. Yes, and you're absolutely right. there usually TSH is ordered, and a lot of labs have a reflex T4. So if the TSH is normal, they won't even add that T3 or that T4 on. They will just leave it off. But if the TSH is normal, then it'll reflex and add that on, meaning the test will be added on to look to kind of delineate what the cause is. Oh, okay. Lucy is back on her computer now. She was on Walter's computer. All right. Well, Walter was getting all the credit then. Becca's going to send the link for the Google form. So hold tight on that one. Okay. So let's move on to the next slide here. So if you wouldn't mind here, same as how we kind of marked whether or marked where we were at on the map. Tell me, guys, is this ultrasound, is it normal or abnormal? Let me know. In terms of the question that just came in, Graves, they would test positive for anti-thyroid stimulating antibodies. A little bit different, but very similar in nature in terms of it is an autoimmune etiology. Yeah, go ahead.
Is this an ultrasound of her neck?
Yes, good job. Good job asking where it's at. You're absolutely right. We're looking at her thyroid. We're doing an ultrasound of her neck. Good question. I wanted someone to ask me that. Good job. Everybody's saying abnormal. Somebody tell me why this is abnormal. Close. Marlon says there's a mass, potentially. So what do we see here? They're kind of measuring it for us. So we see this here. Is this kind of length, even at your level? Imagine this here. This is the length that we're looking at primarily. What's this structure? So imagine that the ultrasound probe is coming this way. So this is kind of posterior, and this is anterior. Meaning anterior meaning front, posterior meaning back. Looks like she swallowed a golf ball. I agree with you. She did. It looks like she has. Spine close. What's windpipe? Perfect. Yeah, that's our trachea right here. So we're looking at our trachea, the big rigid structure carrying the air to your bronchi and your lungs. So we're looking at this part here. The thyroid kind of sits in front. Now I have to write like T. Here, I'll put thigh. There you go. The thyroid is right in front. And is this kind of basically it's showing a kind of a big cross section of it. And what it's showing you is that this is diffusely enlarged here. We should maybe be a little bit smaller here, maybe around here. But this is showing that her thyroid is diffusely enlarged. So you guys did great with that. This is an abnormal ultrasound. So good job. This is a little bit of anatomy as well, which I bet a lot of you guys have taken anatomy at this point. All right, let me clear all this and we'll move on here. All right, so for our differential, things we might want to include here. First one, and you guys mentioned it right away. So I think you guys know a lot more about thyroid disorders than you guys kind of led on at the beginning. Someone mentioned Hashimoto's thyroiditis. What kind of led us to that impression that we might be looking at an autoimmune? Yeah, good job, Holly. Perfect. The antibodies, and specifically, we're looking at those thyroid peroxidase antibodies, also known as the anti-TPO antibodies. So that's what this is right here, anti-TPO. Someone asked if Graves' disease, so I'll write it over here, and I think I have another slide about it down the road, but Graves' disease is thyroid stimulating antibodies, so it's anti-TSI. And then the kind of treatment and pathology for Graves' disease is a little more involved. And we'll talk about that as well. We'll talk about the treatment towards the end. But we think it's autoimmune hypothyroidism, also known as Hashimoto's thyroiditis, because if you remember from her case, she said that she was feeling great, had a lot of energy until she got a viral illness. So she got a viral illness, and a lot of times in the pathology of Hashimoto's thyroiditis, they're fine. As you can imagine, the autoimmune sort of antibodies can be there this whole time. It'll just spring up. But what kind of precipitates this is an illness. And that is exactly what we saw in this case here. And then other than this, the pattern that we look for is an elevated TSH, and we certainly had that, and then a low T4. And that sort of comes along with the symptoms that we saw, the low metabolism, everything's kind of slowed down in hypothyroidism. It's exactly what we saw here is a low thyroid hormone, a low T4. So we saw the weight gain, we saw the bradycardia, we saw the fatigue, we saw constipation. Everything is just slowed down. If you think about it that way, study basically smarter, not harder. Remember kind of this overarching theme, and then plug the rest of the stuff in, okay? Is it always associated with a viral illness, or it could be a family history of hypothyroidism? It can go either way. The way we kind of see it is the antibodies can be present, and sometimes the viral illness precipitates this. So we can think of it like that, but it's not always kind of preceded by a viral illness, okay? And then of note, the thing about Hashimoto's thyroiditis is often what happens is you have a hyperthyroid state. Think back to her case. She said she had a lot of energy at one point. So she might have been hyperthyroid and just didn't realize it. Then she was kind of euthyroid, aka normal. And then now she's presenting with a hypothyroid picture. So that's kind of what we see is like hypothyroid when the thyroid hormone is released due to the viral illness. So you kind of get like a thyroid toxicosis picture. Then normal, because the thyroid is really on its way to burning out. Then the other thing kind of comes along with what we mentioned here is post-viral thyroiditis. This is possible, but due to the fact that we have these anti-TPO antibodies, we're looking more at a really autoimmune etiology of this. And then hypopituitarism. This basically is a secondary hypothyroidism. This is less likely. We're not seeing any other symptoms consistent with hypopituitarism. We would see, as you may know, the pituitary is kind of the master gland for sending out all these hormones that regulate the body. If it was a problem with the pituitary, we would more likely see other sort of hormone deficiencies, imbalances, other symptoms that would lead us to this. Problems with vision. Classically, if there's a pituitary tumor, a lot of times you'll lose your peripheral vision, things like this. Will we see a low TSH with low T4? Absolutely, that's exactly right. We see low TSH, low T4. Okay. So let me clear that. Let's go on to the next slide. So let's talk about our assessment and plan. Before I kind of get into that, does anybody know what the treatment is or how we're going to treat hypothyroidism? It's pretty similar regardless of the etiology, with the exception of if it's a pituitary adenoma. Levothyroxine, good. Synthroid, exactly. So as you'll learn, there's 100 drugs to treat one thing. There's often 100 ways to say the same thing. Levothyroxine is the generic. Synthroid is the brand name. There's also like synthetic. It's from pigs. It's not really recommended. A lot of endocrinologists kind of stray away from that. Kind of being that we aren't pigs by nature. We do have a different immune system, yes, but endocrine system. And sort of correspondingly, it's better to use sort of these synthroid levothyroxine. So good job. you guys are right on the right track here. So begin levothyroxine or Synthroid. And basically, calcitriol is sometimes used. That is true. And we want to return in 3 months. Why? Why do we want to return in 3 months? Other than that, we want to make sure that she's euthyroid this time. Yeah, good job. It takes a while to see an effect. It does absolutely take a little while. So basically what we say is 3 to 5 months to retest and to see kind of a trend back to normal in terms of the thyroid. Education on how to take it. So along those lines, what do we tell our patient? How should she be taking this medication? Yes, somebody asked a question, then typically after every 6 months. Exactly. Yeah, if they become euthyroid meaning their thyroid labs are within normal range, we can extend to talk to them, basically retest their thyroid levels about every 6 months. Great. Take without food. Good. How long do we have to tell her to wait? To eat, that is. Early in the morning. Good. An hour. Okay. Can she take it on an empty stomach with other medications? No. Yeah, absolutely right. Okay, good. What about if she skips a dose? She forgot she was busy. She had a big case. She had to get to the courthouse because she's an attorney. And she ran out the door and forgot to take her levothyroxine. Can she take 2 the next day?
No.
You actually can. So you can. Good job. So you actually can take 2 the next day. The reality of it is it's basically like a loading dose. If she takes 2 of her thyroid medications, if she takes all of her thyroid, we don't tell people to do this, but if she took all of her thyroid medications 1 time in the week, it's going to have a similar effect in that it's basically like a loading dose. Obviously, we don't tell our patients to do that. But if she skips it, we can take it because we want her to kind of have that constant level of thyroid hormone to regulate her thyroid. Okay. And then we want to monitor for resolution of symptoms. We want to make sure her weight kind of balances out. We want to make sure all of those symptoms that she had, including her fatigue, sort of are managed basically. And then we want to make sure that bradycardia is due to her thyroid disorder and not that she has some sort of sick sinus syndrome or something going on with her heart, maybe a heart block, something that's causing a lower heart rate. Okay. And then education surrounding myxedema coma. That's kind of a complication of thyroid hormone. We want to talk to her. We want to educate her about the importance of taking this medication. She's going to have to take this medication for the rest of her life. And so it's important to talk to her about the importance of it, because if not, we can run into this problem of myxedema coma, and this is life-threatening. And I think that's the last. Okay, so now we're going to talk a little bit about the pathology of it. I've drawn a diagram for you, not because I'm a fantastic artist by any means. This is probably a very simplistic diagram, and I hope it helps you. I have, in the next slide, I have like a more complicated one, and I was like, I'm just going to draw one out so that it's a little easier for you guys. Are we a PCP in this case or internal medicine? I would like to say internal medicine. That's what I'm applying to. But at any rate, she's following up with us. We're probably in a primary care setting, so we'll just say that she's following up with us, outpatient primary care. Okay. In terms of hypothyroidism, what we're talking about in terms of pathology is an insufficient production of thyroid hormone. As you can kind of tell with this patient, she had a low production of thyroid hormone, and what caused that TSH to be high basically is a result of the thyroid axis. The thyroid is a very smart organ, and basically what it does here is, as we can see we're working from the top down on this diagram over here. So here's the hypothyroid, or the hypothalamus, located in the brain. It releases a hormone called thyroid releasing hormone, TRH, which acts on the pituitary to release a hormone called TSH, thyroid stimulating hormone. So for once, this is one of the very few times this kind of just makes sense the way it's named, because you're gonna come across a lot of things and the way it's named just makes zero sense. Love this, at least it makes a little bit of sense. Is it once daily or dependent on the individual? In terms of the medication, it usually is once daily. And what we do usually is start out with a lower dose, maybe 50 micrograms, 75 micrograms, and then we work up. If her TSH is still high, then we'll want to increase her dose. So we kind of do it in a stepwise function. We don't just sort of bombard her with 150 micrograms. We want to work up, because we don't want her to go into thyroid toxicosis. It certainly depends on the medication, but we want to do it in a stepwise fashion. Okay, then the TSH, the thyroid stimulating hormone released from the pituitary, acts on the thyroid. And then that's where the thyroid hormone is released, which acts on all of the peripheral organs to stimulate them. But the thing about this is, for hypothyroidism, when this is low, so we know that in hypothyroidism, we have a low thyroid hormone over here. And what it's going to do is basically act back on the pituitary gland, saying, hey man, we don't have any thyroid hormone. Please release some more TSH. So what happens is TSH is being released, and we're getting a lot of it. As we can tell, our patient's TSH was 10. So it was very elevated. So that's what's happening. We're getting more thyroid stimulating hormone to try to act on that thyroid, of which is sick. We have antibodies. This is my rendition of an antibody. Here you go. I'll draw another one so you get the idea. And I put the thyroid meticulously in a heart because we're talking about it today. We love our thyroids. So there's our thyroids, our TPO antibodies. They're acting on the thyroid, and basically, oh, that was a horrible O, but it's acting on the thyroid. It's basically making it sick. It can't release the T3 and T4. We're getting low T3, T4, and then it's acting back, saying, pituitary, please release more thyroid stimulating hormone. And that's how we get the labs that we do. I hope that makes more sense. I know I kind of left you in the dark at first, basically with intent that we would talk about this a little bit more later. So I hope that makes a little more sense. We had another question: if her TSH falls back into normal levels while on medications, but her symptoms like fatigue and coldness persist, what would that mean? Sometimes that happens, and that's just the reality of it. If her thyroid is euthyroid based on labs, but she has symptoms still, maybe if we saw coldness in terms of her hands turning white, blue, and red, we might look towards Raynaud's. I know someone mentioned that before. A very wise student said that. Positive feedback mechanism. Exactly. Yeah, this is a positive feedback. Good, good. That's exactly what this is a feedback mechanism. Okay. And then in terms of hyperthyroid, I kind of color coded this because my brain works like that. So hyperthyroid here is a little bit red, means it's high. We have excess production of thyroid hormone. So basically, it's almost the opposite of what I had just drawn out. But what we talked about a little bit and how we delineate is through primary, secondary, and tertiary. Tertiary, that's the one that we're looking up here. That's the hypothalamus. That's what I've in here. That's fairly rare, tertiary hyperthyroidism or hypothyroidism. Even tertiary hyperthyroidism is very rare. So if you're ever shadowing or with your attending, don't suggest tertiary just by sheer odds. You're probably better off always going with primary just by numbers. Secondary, it certainly happens. What happens, I have a picture coming up, but The pituitary kind of sits in the sella turcica like this. And basically when you have a tumor here, it kind of crowds out all those other cells. And basically it leads to a decreased TSH. And then in hyperthyroid, also rare, but you have a TSH producing pituitary adenoma. So you can have either kind of rendition of that. Okay, let me clear all this. It's starting to look like a mess. All right, if you guys have any questions, feel free to continue to ask those. You guys have had great questions tonight. I appreciate the feedback. Okay, so in terms of the risk factors, what we want to talk about for hypothyroidism is our autoimmune causes. So that's Hashimoto's. We want to talk about iatrogenic causes. So this would be primarily in for instance, Graves' disease. And when I told you that the treatment is more involved in Graves' disease, I mean it. Because Graves' disease, what you do really is you ablate the thyroid or you excise the thyroid. And then obviously, as you can imagine, if you don't have a thyroid anymore, that therefore makes you hypothyroidism. So, and iatrogenic just means it's healthcare associated, healthcare caused. All right. And then other medications such as lithium. Does anybody know what lithium is used to treat? And does anybody know what amiodarone is used to treat? Bipolar. Good job, Holly. I suspect Holly has a lot of healthcare experience. She knew that right away. Anybody know what amiodarone is used for? Good. Yeah, we use amiodarone oftentimes in ACLS algorithm as well. Pituitary adenoma, we talked about that a little bit as well. Post-viral is a cause. Congenital, we see that less often in the United States due to iodine supplementation because iodine is used in the synthesis of thyroid hormone. For simplicity's sake, I didn't include the mechanism for the production of thyroid hormone, how it's synthesized. I didn't want to bombard you with that. And then resistance to thyroid hormone can also cause a hypothyroidism state, but that's very rare as well. And then when we talk about hyperthyroidism, we talk about sort of Graves' disease, which is anti-thyroid stimulating antibody. So there that is again for repetition's sake. I once had a professor that said they used to say in his class or something when he was in med school that a professor would repeat things very frequently, and then he would say, okay, for the C students, and then he would say it again. So that's not the case here. I just want you to know thyroid stimulating antibody. But then also we can consider toxic multinodular goiter. There's that word again, goiter, or adenomas. Postpartum thyroid toxicosis, so after giving birth, and then post-viral thyrotoxicosis. So as you can see, a viral syndrome can cause both thyrotoxicosis and it can also cause hypothyroidism. And then here's that TSH producing pituitary adenoma again. All right, guys. So let's go on to the next slide here. I think we're getting close to the questions, so you guys can. Oh, and here's the feedback here. So, and we're talking about negative feedback in this instance. We're talking about if there's enough of the hormone, it's going to feed back onto the gland and tell it, okay, we have enough, so let's shut it down. Whereas in the pathology stage, we see positive feedback because it's telling the organs, hey, please make a little bit more. So it's a positive feedback, turning on the system. As you can see, here's thyroid releasing hormone, thyroid stimulating hormone. They even added an extra part to their diagram. So I guess they might have one upped me. They added a little blood vessel here to show you it travels to through the blood and into the thyroid sensitive cells. So we have another question. if it's not extremely large, how would you tell the difference between an enlarged thyroid and an enlarged lymph node? So mainly because the thyroid sits right between your sternocleidomastoid muscles, and it's right here. You can feel it on yourself. And the way we test in an exam is to tell the patient to swallow. So if you've ever been at the doctor yourself and they say to swallow, that's what they're looking for, is for the thyroid to move up and down, because what it does is it'll move up and down between your fingers, and you'll feel it come across your finger pads, and you'll be able to tell if there is a nodule in the thyroid gland itself. As you can imagine, you can see in this picture here, if there's a nodule there, you might be able to palpate that. Other than that, the lymphatic chain, posterior cervical, anterior cervical, run in a different distribution. Then you have supraclavicular, and then it's a little bit different in terms of anatomically. That's how you can basically tell. That being said, if you have a thyroid cancer, if you have a problem with your thyroid, you might also simultaneously see enlarged lymph nodes as a result. Okay. So here's our diagnosis and evaluation. I suspect that you guys are hopefully pretty good with this. I want you to pay attention to a few things, and they'll come in handy later. Call it foreshadowing, but pay attention here if you haven't been thus far. Here's the dry skin again. The one I want you to pay attention to for hypothyroidism is a few things. I want you to pay attention to that bradycardia, and I want you to pay attention to this delayed relaxation of deep tendon reflexes. The way we see it often is in the Achilles tendon when you're testing that reflex. What you'll see basically is when you test it, you hit the tendon and it kind of reflexes through the system. It'll go quickly and then slowly back to normal. So you'll hit it, it'll go quickly and then slowly back to normal. Whereas if it's normal, it'll go quick. You guys have probably maybe seen a little bit of deep tendon reflexes thus far, but that's a pretty specific finding for hypothyroidism. And as you'll kind of learn, it's important to keep in mind those symptoms which are specific to a certain etiology. Then the other things that we want to pay attention for hyperthyroidism, let me change my pen here to be congruent. Weight loss, sweating, that's kind of the opposite of hypothyroidism, and then atrial fibrillation. I want you to pay attention to this one. I'll put stars here. It's starting to turn into a sun, I think, but pay attention to atrial fibrillation and pay attention to this tremor. Basically, this increased surgence of the increased surgence of thyroid hormone will cause the atrial fibrillation and cause the tremor as well. You just have this overactivity. And similarly, you'll see hyperactive deep tendon reflexes. And this exophthalmos is pretty well associated with Graves' disease. It's those people who you kind of see their eyes popping out of their head. If you're at the mall one day and you see their eyes popping out, I always like to look for the people, and you'll see this too. Whenever you get trained, you kind of see people out and about, and you're like, oh, they may have this, but that's part of your training. You'll see that. Can you tap the cheek for facial response for hypothyroidism? That's a little more for hypocalcemia, James. And what you'll see for hypocalcemia is you'll see that's called the Chopstick sign. All the foreign things I can't pronounce very well. And then you'll see Trousseau sign for hypocalcemia as well, where you pump up the blood pressure cuff and you'll see spasms because of the hypocalcemia. Similar, a little bit different. We'll see the delayed relaxation for the hypothyroidism though. That's a great question. Okay, let me clear this. Let's go on. All right, so, and I kind of alluded to this a little bit before here, but we'll talk about it a little bit again briefly. Mixed edema coma is the risk associated with untreated severe hypothyroidism. You're gonna see these people very, very sick. They're gonna have altered mental status, they're gonna be lethargic, they probably won't be communicative with you. Their family might bring them in and say, you know, they're not talking, they might be very cold. They might be hypotensive. They might have a low respiratory rate. And these are all signs that we want to act quickly, especially if they're hypoventilating. We might have to intubate this person, act quickly. This warrants ICU admission. We want to give them IV levothyroxine, potentially steroids. And on the other side, thyroid toxicosis. You probably have heard of thyroid storm before. This also warrants a ICU admission. We might want to give them beta blockers to slow their heart rate and give them high dose antithyroid medications. And then other associations is atrial fibrillation. There it is again, remember that one, and then osteoporosis as it affects bone remodeling, thyroid hormone. All right, so I have a poll for you guys. So the next few questions, what I'm going to ask you is whether this is hypo or hyperthyroidism, okay? So these should be fairly straightforward, hopefully. Let me see here, let me launch this poll for you. All right, feel free to answer this one. I'll give you guys about a minute or until I see everybody has kind of joined.
Is this for this picture?
Yes, absolutely.
Okay.
Yeah, you got it. All right, great job. We have a few people. I'll give you guys a couple seconds to add in your response. You guys are doing well. Perfect. All right, so that's nearly, let me show the results for you. The overwhelmingly majority of you guys said hyperthyroidism. Somebody please tell me, unmute yourself or put it in the chat. What told you this was hyperthyroidism? Good, yeah. It's called exophthalmos, bulging eyes, perfect. Associated with Graves' disease, perfect. And then a thing to remember for Graves' disease, when you get to medical school, hopefully you remember this tidbit of information. When you treat Graves' disease, often the antithyroid medication doesn't actually treat the exophthalmos. So sometimes you give steroids for that, okay? And you do additional treatments for that. So good job with that. I do have another one for you guys. I have a few more. Let me relaunch this for you. All right, I'll give you guys a few minutes for this one. You guys are doing great again. So for Raynaud's phenomenon, we had a question. Raynaud's phenomenon, is it always associated with thyroid, or are there other things that cause it? It's mainly associated with thyroid because autoimmune conditions kind of flock together. And so there is kind of a different autoimmune association, but if you have one autoimmune condition, you're more prone to getting another. So that's why we kind of keep our eyes peeled for other autoimmune things. Okay, so great job with this one, guys. You did very, very well with this. 94% of you guys said hypothyroidism. What is probably the most significant thing that tells us maybe this is hypothyroidism? If you had to pick one symptom that you said that you were thinking hypothyroid. Low heart rate, okay. Anybody else? Fatigue, good. Great, weight gain, yeah. I'll tell you, often if I see someone that comes in with a substantial weight gain and they're not trying to gain weight, or their diet is very good, they exercise a lot, or the other thing you often see commonly is women or even men who are exercising very vigorously and are not losing weight. That is more common for us women, unfortunately. But if I see that and they're eating very clean, then I, in my head, I'm more prone to get a TSH, thinking this might be a thyroid problem. Are behaviors or genetics a bigger contributor to the development of hyper or hypothyroidism? Primarily genetics. Hypothyroidism, there can be kind of behaviors associated with it in terms of like exposures and things, but overwhelmingly likely genetics. Good question. Weight gain plus fatigue plus bradycardia. Lucy wanted to give us all three, and you're absolutely right. Okay, so I have a few more for you. So let me stop this and relaunch the polling, and let me play this video for you. I'll play it one more time just in case you guys missed it. And then one more time in case you really missed it. All right, a few more seconds for you. You guys are doing well. Okay, so this is, you guys indicated to me that this is hyperthyroidism. What is he showing us? Why is he showing us his hand? Is he showing us his wedding band? What is he showing us? Tremor, good. What this is kind of showing us is a good, everybody says tremor. This is a fine tremor too, and I know that this may seem like a foreign concept to you. I like Julia's answer. She put an up carrot. That's perfect. So I couldn't tell if it was the patient or that's a good point. That's a very valid point. If it was the patient or the cameraman, either way, we're going to say that this is hyperthyroidism. And what he's showing us is a fine tremor. As you guys are going to kind of learn, there's different types of tremors. You can see a flapping tremor in liver disease where because of the buildup of ammonia, you're going to see them kind of put their hands out and they're going to go like this. And it's going to be and kind of a really bad joke that I've heard that I still remember though, and I don't know if it's a joke, but I've heard people say that when you see it, it's called a flapping tremor, and it looks like they're waving to you because it's an end stage cirrhosis. So I've heard attending say that they're waving goodbye to you. Yeah, kind of sad. I don't love that, but if it helps you remember it, so be it. Okay, good, great job, guys, with this one. Let me go on to the next one. It's trying to play the video for you again, in case you missed it. All right, here's the next one. Let me relaunch this for you. Let's see. You guys are doing great so far. Let's see if you can keep up your trend. All right, guys, great job. Good. It even gives you her treatment if you guys missed that. It tells you she's on, she's been for 3 years in 2014 on T3 and T4. All right, we have 33 of you guys on. Let's see here. A lot of you guys, I thought this one was going to be the easiest one for you guys. So she had, it looks like hypothyroidism for a few reasons. Other than the fact that it gives you her treatment, what tells us that this might be a hypothyroid case?
Weight gain.
Yeah, good, exactly. Yeah, so it looks like she had a little bit of weight loss after treatment. We can look at it either way. She had weight gain and then lost it, or vice versa. So great job, the weight difference. Good, good. Perfect. And then there was a question, does hypothyroidism have any tremors associated with it, or is it a hyperthyroidism thing? It's a hyperthyroidism thing. So it's due to the increased metabolism, the influx of increased excess thyroid hormone that's causing that tremor. All right, I think I might have one more for you guys. Okay, so here's another video for you. Let me relaunch the polling for you, and this might be one of the last ones. So let me play the video for you. Good job, you guys are doing great. Great job. Surprisingly, this might have been the easiest one for you guys, and I thought this would be one of the harder ones, but you guys did great. Okay, so this was hypothyroidism. What did we see here? What was he showing us? I mean, with the deep tendon reflexes, he could be certainly showing us one of two things. We talked about two different things, hyper or hypothyroidism. So increase deep tendon reflexes or delayed. Good, good. Delayed deep tendon reflexes is what we're looking for. And hopefully my my rendition of that kind of helped you before kind of see that. You know, as we can kind of see here, we can kind of get a good look at it and see that what's happening is he'll hit the deep tendon there, the Achilles tendon, and the outward motion is perfectly fine. It's kind of the reset that's very slow. That tells us that that is hypothyroidism. It's resetting very slow. It's telling us there might be a problem here. So as you can kind of see, his reset back to normal is pretty slow. Usually, you know, you can test this on your siblings or your roommates later and test their deep tendon reflexes. They'll reset normally. And for this one, we didn't see that. Okay. Let's see here. I think I might have maybe one more, or maybe that's it. One more. All right, let's relaunch. Great job, guys. You guys are doing well. All right, we've almost all of you in. All right, way to go, guys. I guess my stars that I drew around around the atrial fibrillation helped you. So this is certainly a hyperthyroidism associated pathology. Often, if we have somebody coming into the ED with atrial fibrillation, that is hyperthyroidism is certainly going to be in our differential diagnosis. When we see atrial fibrillation, we want to look for treatable causes of atrial fibrillation first. So we definitely want to look for things like hyperthyroidism, electrolyte abnormalities, things like this. So good job, guys. Dry skin for the feet. Yeah, that can certainly be a cause in the last video that we saw. That could be a hypothyroidism thing too. Or I don't know, maybe that doesn't pay attention to their doesn't see or doesn't attend to their feet. New onset atrial fibrillation, that's absolutely right. Yeah, good correction. If they present to the ED with new onset AFib, that's absolutely right. All right, guys, I think that was the last polling question. Let's see here. All right, so what I have here for you is a little cartoon to show you Graves' disease. We spent a vast majority of the time talking about hypothyroidism. So I wanted to make sure that we talked a little bit about Graves' disease. So this is also autoimmune. Autoimmune things we often see in women. We can see the tachycardia or an arrhythmia, such as atrial fibrillation. We'll want to, if our patient comes into the ED, we'll want to look at causes, treatable causes, even if they have a known history of atrial fibrillation and perhaps have a history of thyroid disorder. We're going to want to look at their TSH, and especially if we can treat that. Exophthalmos, so we see a gross exaggeration of the eyes popping out of the head here, and loose stools. So you'll see diarrhea and Graves' disease as a complaint. All right, so this is one of my last slides here. So treatment, as we kind of talked about, we treat hypothyroidism we supplement with thyroid hormone. We give them what they don't have. Hyperthyroidism, we kind of stop what they have in excess. So antithyroid medications such as propylthyroid uracil and methimazole, those drugs inhibit enzymes of which are involved in the synthesis of thyroid hormone. So that's probably all you need to know at this level. And then, as I kind of mentioned before, for hyperthyroidism, the antithyroid medications are usually just temporary, because what we want to do is have a more permanent solution to their problem. So we'll want to do either radioactive iodine ablation or excision to treat their hyperthyroidism. And then we can give propranolol for symptomatic relief, especially if they have a tremor, if they have tachycardia, things like this. And then over here, we see this table. Hopefully it's not making your eyes go cross-eyed at this point. But the things that I want to kind of draw your attention here are, we talked a lot about primary. So we want to talk about primary hypothyroidism untreated. And what we're going to see is that high TSH. So we're going to see high and then low T4. Okay. So I have one last thing for you guys. Let's see here. I want you to, I have one more poll for you. And that is going to be our post poll. I want you to fill this out, and I want you to be honest. If you learn nothing, that's okay. Let me know what kind of your take is now that we have spent an hour together on a Friday night talking about the thyroid. Good. So we have 35 out of 35 people in, and let me end this and share it with you guys. So we have nobody saying they know nothing at all, which makes me feel good as a presenter. I love that. And nobody saying a little. So good job, guys. I didn't expect you guys to know an extreme amount at this level. Thyroid can certainly be a challenging topic to learn. A lot of people don't like endocrine because it's very involved. I hope that you guys take the time to learn it when you're in medical school and put in the time, okay? So here are my sources, probably mostly pictures. I'm a very visual person. And then what's next for you guys? If you want to get the certificate of completion, please fill out the 10-question quiz. It should be, I made sure to write the questions very meticulously so that if you were active in the session, you were paying attention, you will be able to answer these questions. If not, you can email me and I will help you with them. I have faith in you that nobody will email me because I think you guys can do it. Then coming up, you won't see me for a few weeks. I'll be back in, I think, 4 to 5 weeks to teach you guys. In the meantime, my colleagues will be talking with you. We have a surgery session about cholecystectomy coming up next week. And then we have a few emergency medicine sessions. And then we have one about cardiology. So And then you guys, Becca mentioned to you guys, you can go back and watch the session later. Please subscribe to our YouTube page. Give us a thumbs up if you like the session. Subscribe to us. Hit subscribe. We would love that. We hope that this was a valuable use of your time. We certainly have put in a lot of time and effort to make this something of which it would be worthwhile for you guys. And hopefully it was. I know we took up a little bit of your time on a Friday night, but hopefully it was worthwhile. Our next session will be on Wednesday, next Wednesday. So share this with your friends, let them know if this was helpful for you, and we'll see you guys on Wednesday. If you have any questions, I'll stick around for a little bit and answer any questions you guys have. Do they continue throughout the summer? Absolutely, Holly. We'll be here through the hot weather with you guys. If there's any questions, I'll stay on.
I just wanted to say that I didn't have the opportunity to say that I didn't know anything about the endocrine system before this, and obviously I learned a lot, so thank you.
Well, thank you. Thanks, Cameron. I appreciate that. I'm glad that you know a little bit. Endocrine can certainly be a challenging topic, and any little bit that you can learn, take advantage of it.
Understandably so. Thank you very much. I hope you have a good night.
Yeah, you too. Take care.
I also want to ask, because my school just sent out an email about this program that y'all have, that you're hosting. And so I just learned about it like a few days ago. Where are y'all located?
Holly, I think you're cutting out a little bit. I hear your mic going in and out. I didn't hear you. I don't know if anyone else was able to hear or not.
Sorry.
Okay, there you are.
My computer is having issues with Bluetooth headphones really badly.
That's the story of my life. I understand.
My school just told me about this program this week. I had no idea this existed, and so but they didn't really give us any information about y'all, just besides virtual rounds. So where are y'all located? What is this program about?
Yeah, good question. So we started this in January. So Motivate MD is primarily a service dedicated to students, kind of helping them in their journey. We do a lot in the way of essay editing. We do a lot in the way of mock interviews. Speaking of which, that's how I got my start with Motivate MD, is through essay editing during the application season. So if you see that that's of benefit to you, you can certainly reach out to us for that. We created the virtual rounds program in January to kind of basically offset the problem that we're seeing with COVID is that a lot of people, a lot of pre-medical students can't get into the clinics to shadow. So we created this for kind of a solution for that, and to kind of get you guys more exposure to real cases, realistic cases presented by medical students and physicians. So that's primarily our goal. We did start with this being every 2 weeks, and now we're going every week. So we hope that you can join us as often as you can. I hope that answers your question, Holly. Absolutely.
Hi, thank you. I had a question. So when we go on the link, the first thing that we see is the SOAP notes.
Mm-hmm.
So that's like off the case that we went through the study today, right?
Yes, you got it. Exactly. Yeah, so you're going to fill in that information kind of as best as you can, the subjective, objective assessment and plan.
Can I just get what the HPI and ROS stand for again?
Yeah, absolutely. So HPI is history of present illness. So that's going to be primarily kind of a surrounding, basically what the patient's telling us. So she came in and told us that she's an attorney. She told us that she's fatigued. She told us that she's gained weight. So it's kind of basically a paragraph, the story of the patient. So the way I would write it is, you know, for instance, let me annotate this for you. So the way I would write it is, this is I think she was like 33 or something. This is a 33-year-old female presenting with increased fatigue for 2 months. She notes additionally weight gain, hair loss, stuff like that. All the things, does that make sense? All the things that she kind of
Yes,
going
absolutely.
on. So you're just almost writing a story of what she told you. And then the ROS is going to be pertinent positives and negatives. So often the ROS is listed as a just a list. So we can say positive weight gain. She also had hair loss. You can say fatigue. She had dry skin. And then one of the pertinent negatives was depression. So we can say no depression. So that's basically what that looks like. Obviously, this is going to be a little more involved here.
Okay, thank you.
Does that help?
Yeah, that helps. I'm writing it all out in paragraph form. Thank you.
Perfect. Sounds good.